by Shyam Aggarwal sir. Shyam Aggarwal sir is a director of medical oncology from Sir Ganga Hospital, New Delhi. And today he will discuss regarding the evolving treatment paradigm with immunotherapy in endometrial cancer. So over to Shyam Aggarwal sir. So, so as we know that so we will discuss today regarding the MSI proficient tumors and MSI deficient both tumors of endometrial cancer. How we can use immunotherapy in these.
Yeah, so sir is joining in a minute or so just hold on for it. Yeah, I'm sure this sir has joined. You can please introduce.
Good evening, sir.
Good evening.
Yes. Uh, so, sir, over to you, sir.
Okay, so thank you very much for invite. And this is a sponsored session by GSK, which is going to be focusing on immunotherapy of endometrial cancers. So can I have the next slide, please? Okay, so this is to showcase the number of patients, at what age they are diagnosed. As you can see, 85% of these patients are postmenopausal, and the median age is 63 years. And people who have lower socioeconomic status, they do worse. Next slide, please. This is the percentage of patients and the 5-year survival depending upon their, the stage of their disease. And as you can see, 67% localized and 19% regional. And the survival for these patients is good, as 5-year survival is 94 and 70% respectively. However, with distant metastasis, the survival is quite low to the tune of 19%. So next slide. So in India, nearly 20,000 new cases are diagnosed each year. And the prevalence, goes up to 53,000 because, these patients, as we said, are in early stages and therefore they survive. Next slide. So these are the, figures in terms of increasing incidence, increasing mortality, and the, as the people are elderly, so the, the issue of survival is there in these patients. Next. Okay, so these are the chemotherapy outcomes where we, by and large, use Pacli and carboplatinum in the first line of these patients. And as you can see, that the doublet of Pacli carbo doxorubicin cisplatin. I think the triplet does give you some additional advantage in terms of overall survival, but then the toxicity for these elderly women precludes us to use triplet. And the reason, therefore, for this is to use a doublet by and large, which is based on a taxane and a platinum, which is better than the single agent like doxorubicin. Next slide. However, as I showed you, the PFS is usually less than 1 year, and so there is a lot to be done in terms of improvement in their PFS, and ultimately it has to translate in terms of overall survival. Although response rates are good, but then patients tend to relapse quite rapidly. Addition of drugs like nintedanib, as shown in this curve, have not given additional benefit. So for advanced and recurrent, until recently, carbopacli was the treatment of choice, and PFS is less than 1 year. Next slide. So these are the second line and subsequent line therapies where people have used drugs like pegylated liposomal doxorubicin or ifosfamide or docetaxel, etc. And as you can see, they have a fairly low response rates to the tune of 5 to up to 20%, and 5-year survival remains dismal, and the median overall survival is less than 12 months. One thing which is missing is the use of hormonal therapy like megestrol acetate or medroxyprogesterone acetate. So these are also available, and sometimes they can give a very heartening response and survival, and they are used in third line or fourth line treatment. And so they should not be forgotten in patients with endometrial cancer who failed first line chemotherapy. Next slide. Next, please. So this is the ESMO guideline recommendations for patients with recurrent or metastatic endometrial cancer. And so things are evolving. As you can see, paclitaxel remains the main treatment, and then you need to split between MSI high and MSI low or proficient MMR. So, and these lines are also getting a little fudgy now, as you will see in the subsequent trial, which I'll show you. For patients who are MSI high, a drug like dostarlimab can be used as a single agent or in combination with platinum. So these are older guidelines, and patients who are proficient MMR again are eligible for chemotherapy like platinum and platinum. But then, as I said, I'll show you the latest slides after I've shown you the data. So immune checkpoint inhibitors were earlier reserved for patients who are platinum refractory or who are not responding to platinum. Next slide, please. But then these things are changing very, very rapidly. So again, these are old guidelines depending upon the MSI high. So dostarlimab is used as a single agent like other pembrolizumab and avelumab for proficient MMR tumors. And this is in second line after the patients have failed chemo. Their Lenva and Pembro would become a very important drug for proficient MMR or a combination. For HER2 positive patients, one needs to use TDXD in the second line. For the other recommended regimens are, as I just told you, are revolving around doxorubicin, pegylated doxorubicin, and gemcitabine. Next. So this is the game-changing the subtyping molecular basis in which you tend to use P53, MSI, POL, and no specific molecular profile. And this is the distribution. Although this is much more relevant to the first and second stage of endometrial cancer, where nearly 20% of the patients, based on the this molecular profile, will be upstaged, and therefore they might become candidates for radiation and or chemotherapy. But the more relevant for advanced stage is the use of MSI. Next slide. So you can see in the endometrial cancers, MSI high is seen in almost 25 to 30% of the patients. So which is a very high number. Next slide. So what's the rationale for using immunotherapy? I think we all know because if somebody is MSI high, because of which the proofreading, the mismatch repair gene machinery is mutated, and there is a, the mutations lead to high new antigen load, and that results in the tumor infiltrating lymphocytes, but they are inhibited, and the immune checkpoint inhibitors release that brake, and the TILs will become activated and kill the tumor cell. So next slide. So patients who are MSI high have a large number of mutations, as a result of which there is a huge, new antigen load to the tune of 1,000 new antigens. So this is what I explained to you, that the TILs, which are, or the lymphocytes which are lying dormant because of the PD-L1 breaks, dostarlimab will, release that break. Next slide. So these are again the data from a single drug or maybe a combination in second line after having, given chemotherapy. And as you can see, across various immune checkpoint inhibitors, the response rate is to the tune of 50 to 60%. And the PFS is hovering around, 13 to 15 months. So, which is a good achievement for patients who are dMMR, that is MSI high. So, this is a sort of a class effect for these immune checkpoint inhibitors. Next. So, I think this we have already covered. Next slide. So, what I'll do is I'll go to the Ruby trial, which is the use of dostarlimab in combination with chemo, which is carbopacli. And in the second arm, you have a placebo with chemo carbopacli. And if you look at the inclusion criteria, which is very important, so stage 3 and 4 or first recurrent endometrial cancer with low potential for cure by radiation or surgery alone. And they did include carcinosarcoma, clear cell carcinoma, serous, and mixed histology. So, which is a little different from the pembrolizumab trial. So, they did include all subtypes of endometrial cancers. Next slide. So, this is 1:1 randomization, and the protocol was given every 3 weeks. I think the slides are missing here. Are we? Can you go to the previous slide? Previous one, please. So I think there is some problem with the slides here. Suffice it to say that, I mean, I don't know if they can share the slides, but suffice it to say that dostarlimab in combination with platinum and paclitaxel is approved in stage 3 and stage 4, irrespective of the subtype of cancer, which would sort of include carcinosarcoma and clear cell, and irrespective of the MSI status. Irrespective of the MSI status. It's very important. And similarly, Pembro, you can't use in patients with carcinosarcoma. And for HER2 positive, you have trastuzumab. And for patients, other than this, you still have the option of bevacizumab with patients who have measurable disease in stage 3 and 4. So I think this is one important slide, takeaway message that carbo-pacli dostarlimab in stage 3 and 4 is category 1 recommendation, irrespective of the cancer subtype. Next slide. However, next slide, please. However, in patients, so I think now they've got the slides for the Ruby trial. So, you see almost 250 patients in each arm. And if you look at the next slide, please. So majority of these patients were stage 3 and stage 4. And you see the carcinosarcoma here is to the tune of 10%. And patients with DMMR, you see the curves diverging. Next slide. So as you can see, the hazard ratio is 0.28, and this is for patients who are MSI high. So this is a very, very, important data for dostarlimab. Next slide. And this is actually the was the OS, and this is PFS. And again, the hazard ratio is 0.64, which is statistically significant. And this is for overall population. So that earlier one was for DMMR or MSI high, and this one is for patients who are intent to treat population. Next slide, overall population. So the overall survival for the entire group, as you can again see, which includes DMMR and PMMR, the hazard ratio is 0.69, and this is statistically significant. And the duration of follow-up is 37 months. You can see at 3 years, 55% versus 43%. So irrespective, although we can all understand that with the MSI high, the result is much better. The hazard ratio is much better. But then all comers are benefiting. Next slide. Right. So this is the overall survival. Again, you can see a huge difference. Again, the hazard ratio is 0.32 on the overall survival. Next slide. And this is for PFS for PMMR. Again, you see the hazard ratio is 0.76, and you can see the straight line again with dostarlimab, and at 3 years the difference is almost 18% or 10%. Next slide. So this is the overall survival for MSS population. Again, 0.79 hazard ratio, and the p-value is 0.04. So there is an advantage, although less than as compared to patients who are MSI high. Next, please. So these are the response rates. Again, irrespective of the type of tumor, MSI or MSS, you can see the response rates are a little better, and they are driven by the chemotherapy by and large. So results are a little better for patients who are MSI high. Next slide. So these are the curves for duration of response. The best for MSI high, then MSS, and again the overall survival is the duration of response is significant in favor of dostarlimab. So one can use this combination irrespective of the MSI status in all comers, stage 3 and 4 recurrent. Next slide. So this is the PFS2, indicating that there is a carryover effect of dostarlimab after these patients have been exposed to dostarlimab. The outcomes are better with the second line treatment. Also, next slide. So PFS2 again is so much superior in patients who are MSI high, and the hazard ratio, and you can see a huge gap between the two curves, starting at nearly 3 months or so. Next slide. So there is no new signal. Side effects are manageable. So I'll not, get into this. Next slide. So we have another trial to show. So I think you can skip these slides. You can go to the Garnet study if you have it. Next, please. So I think the side effects are not, different from the other drugs. So there is on the PFS, you can see 70% reduction, and OS 68% reduction, and PFS2 68% reduction. So overall population again 36, 31, 34%, and meaningful in MSS 24, 21, 26%. So I think I mean, the data is quite obvious and speaks for the efficacy of the combination. Next. Next, please. Next, skip this. The quality of life is maintained. So this is the Garnet study. Again, if you look at the inclusion criteria, so these are patients who have progressed on platinum-based doublet and for the advanced or recurrent disease, and they're anti-PDL1 naive. And the cohort 1 was for patients who are DMMR. So I'm going to show data for the MSI high patients. Next slide. The Dostarlimab was given 500 milligram every 3 weeks. Can I go to the previous slide? Yeah, so every 3 weeks for 4 cycles, 1,000 milligram every 6 weeks thereafter. Next slide. So this is the response rate, nearly 50%, and a disease control rate of 60%. And the median duration of response was not reached. And at 12 months, a large number of patients are maintaining response, 93%, and at 24 months, 83%. So this is extremely encouraging for patients who are MSI high. Next slide. So I think you see the curves in terms of probability of overall survival. 50%, more than 50% patients have a median overall survival and not reach the median overall survival. Next. So I think the side effects, there's nothing new. Next. So robust efficacy in second line after the failure of chemotherapy in MSI high patients. Next. I think I already showed this slide. So this combination can be used in patients with stage 3 and 4, irrespective of the type of cancer. Next slide. And in second line, and that is the subsequent therapy, if somebody has, so this is the preferred regimen in the first line. But if somebody has not used chemotherapy in the first line, again, the Dostarlimab combination is there. But if you have used chemotherapy in the first line, then you do have the option of the Dostarlimab in patients who are MSI high. And for patients who are MSI low, a combination of Pembro with Lenvatinib is on in the second line after having failed chemotherapy. So I think we must do the MSI testing and HER2/neu testing for all our patients to decide what is the first line and the second line therapy for patients with endometrial cancer. So with this, I'll stop and thank you for your attention.
Thank you, sir. Thanks a lot. So, sir has explained everything to us
I would
regarding
like
the
to
endometrial
have
cancer.
a question with Shyam, sir.
Yeah, Kilhan.
Yes, sir. Yes, sir. So now we have multiple options, including DOE, this Dostarlimab, and also the data of Pembro. So, sir, how to distinguish between the three data sets? Because we can't compare it directly. The cross-trial comparison is the only way. How do you see? Because Dostarlimab in MSI has done extraordinarily well from the rectal cancer data which we have seen. So do you think
Absolutely.
the same thing is going to happen even in other MSI high cancers and other chemo IO combinations with Dostra as well? Do you think, sir?
Yeah, I think so, but then they have to generate data because by and large for MSI high, I think as we understand the rationale of more mutations and more antigen load, so these drugs are likely they work. I mean, you do have tumor agnostic approval for pembrolizumab and for maybe Nivo Ipi. So even Dostarlimab is working on the same lines. So I anticipate a similar efficacy for Dostarlimab, as you've seen in rectum, as you said, and now in these patients, with endometrial cancer.
Yeah. And thankfully, I think phase 4 trials are there in the country for second line setting. What I
That-
remember, Ghanshyam sir is having a phase 4 trial, he told in the last meeting. I think
Right.
we should consider enrolling patients in available trials in the country so that
A
the
similar
patient
data is coming with Durva, as you said, the duo
UAE.
study.
Yeah.
So
Yes,
I
sir.
think we're going to be spoiled for with choices And I think all these drugs tend to deliver. So, it's a question of personal preference.
Yeah. So
So, sir,
thankfully,
still in
yeah.
the first line, it will be chemo IO, means Paclitaxel with either Pembro or Dostarli, and in the second line, now since we are earlier we are using Pembro Lenva in the second line, most patients because they have not used immuno in the first line, but now being immuno being used even in the first line setting. So in the second line setting, we'll be having only lipodox at present or any other thing. Okay, I think so. Shyam sir has. Okay. So Akhil, any comment from you?
No, as I think as Shyam sir was trying to highlight, getting a good quality data is also very important. And thankfully, we have now 3 immunotherapy drugs approved in the first line setting. So DOE is approved. Pembro is not DCG approved, but it is there already. There in the Pembro patient assistance program form, we don't see that. So that leads us to know that it is not yet DCGI approved. DOE is approved and dostarlimab in second line is approved. First line approval yet pending. That is what I know from the.
Right. So that's Akhil leaves an important question, which was asked that what do we do in the second line after having failed,
Yes, sir.
the dostarlimab chemo? So I think possibly we have.
Am I audible? Hello.
Yeah, Shyam
Can
sir, you can continue.
Yeah. So I think NGS can be done at that point. The option of hormonal therapy, as I mentioned in my brief initially, I alluded to. And then, of course, second line therapies with maybe doxorubicin based or certain other drugs can be used. That will be my take. Akhil, what do you think?
Yes, sir. Completely agree. As you told, we are going to be spoiled for choices in the first line setting with the availability of 3 drugs and 3 data sets, good data sets. And let's see how is the personal experience. I think dostarlimab has become available very recently, and most of us have experience of 1 or 2 patients most at present. A good thing is that we have phase 4 multiple data sets and trials coming in. DOE trial phase 4 is being launched. Second line, Dostarli phase 4 already recruiting in the country. I think this will definitely help our patients and the physicians and oncologists to gain experience as well. So that is what is required.